I want to thank everybody for joining us to the first in our Health as Civil Rights series. My name is Michelle Hickey. I am webmaster and friend to the Sankofa Collaborative. A couple of housekeeping notes before we get started. I see most of you are already on mute, and thank you for that. If we could keep that, leave the audio for our speakers, that will help prevent a lot of interference. There will be time for question and answer at the end of the program. So we're asking that you post your questions in the chat box. I will be taking note of them and we'll bring them all back after the presentations are finished. If your question relates to a particular panelist today, just let me know so that I know how to direct your question when that part of the program comes. The program is being recorded, just for your information, and materials will be available on our website probably a few days to a week after the program. So I want to thank you for coming, and I'd now like to introduce our moderator, Dr. Linda Caldwell Epps. Oh, before we get to that, sorry, Sam, you can back up one. I did forget. We want to thank our sponsors. We did receive funding for this program from the Robert Wood Johnson Foundation and Patient First. We're deeply grateful for that. And we do want to note that the views that are going to be expressed here today do not necessarily reflect the views of these funders. And now I'll introduce Linda Caldwell Epps. Linda is president and CEO of 1804 Consultants and a founding member of the Sankofa Collaborative. She has more than 45 years of experience with educational and cultural institutions, such as the New Jersey Historical Society, the New Jersey Network Television and Radio, and she had several positions at Bloomfield College, where she was for nearly 30 years. Her firm, 1804 Consultants, was founded in 2011. She works with history and cultural institutions throughout New Jersey and nationally, and some of these have included the Smithsonian National Museum of African American History and Culture, the William Trent House, Newark Public Library, the Scotch Plains Public Library, Old First Church of Elizabeth, New Jersey, and the Timbuktu Historical Site. So Linda, I'll turn it over to you, and welcome everyone.
So good afternoon, everyone. Thank you for joining us. And what Michelle did not mention is that I have worked with her at, I think, all of those institutions that she listed. We've been friends for a long time, and she kindly consented to work with us with Sankofa Collaborative in bringing you these programs. So I think I saw a few names that I didn't recognize. So I'm going to take the liberty of just saying a few words about the Sankofa Collaborative. We were founded in 2017 by 4 organizations: 1804 Consultants, Grounds for Sculpture in Hamilton, New Jersey, the New Jersey Historical Society in Newark, the Southsburg Sauerland African American Museum in the Hopewell Valley, and the William Trent House Museum in Trenton. We formed the collaborative with the purpose of helping individuals in schools, museums, libraries interpret and discuss African American history. The collaborative takes its name from the Twi language of Ghana, and translating it means go back and get it. And it's often depicted, as you can see on the screen, by a bird with its body facing forward and its head turned back, holding a very precious egg. And this and other Sankofa symbols remind us of the importance of learning from the past. Our mission is to build the capacity of individuals, groups, and organizations to learn about, present, and discuss the complex and difficult issues in the history and current experiences of African American citizens of New Jersey and of the United States. And we are very thankful, in addition to the organizations that Michelle mentioned, to the New Jersey Council for the Humanities and to the New Jersey Historical Commission for sponsoring much of the work that we do. We're a nonprofit entity, and all of us do this because of our love for our state, our history, and for the love of people. So that's the Sankofa Collaborative in a snapshot, and we can move to the first slide for my formal remarks. Okay. So Martin Luther King, in his address to the Medical Committee for Human Rights of the American Medical Association in 1966 said, quote, "Of all the inequalities that exist, the injustice in healthcare is the most shocking and inhumane," end of quote. King's words reflected the feelings of many in the civil rights struggle who realized that the demons of inequality that have always haunted America could not be vanquished without the establishment and the protection of access to good health care. We all understand that this republic of ours is not structured for all of us to have everything. But hopefully we are a bit smarter now and we know inequality and systemic racism are intimately linked. Both have haunted America since 1619 and before, and both cannot be vanquished without the establishment on a national level of systems aimed to protect the rightful access to affordable health care for all. Next slide. 55 years have passed since King made that address, aimed at blasting the American Medical Association and other organizations for what he called a conspiracy of inaction. And he also termed it medical apartheid. That medical apartheid that existed in 1966 is still with us today. I'm just going to ignore. I'm not going to quote statistics or talk at length about the disparities in healthcare. I'm in no way an expert on this topic. We have three panelists who will fill in the information needed to hopefully give credence to my opening remarks. Their professional lives are dedicated to this topic of healthcare as a civil right. And for this panel, racism and health. My experience regarding this issue is personal. And like many of you, I've witnessed discrimination and have had to be advocate for many, including myself, as I have endured an illness for 30 years that when diagnosed, the lifespan for Black women was 5 to 10 years. I've witnessed firsthand disparities, and all of you are witness to the COVID health crisis we have lived with over the 12 plus months, and well know the high rate of transmission and death among people of color. Those whose low paying jobs are considered essential, and when I last checked, accounted for only 2 to 3% of those who have received the vaccination. If you are Black or brown or poor of any color, I'm sure you have heard the personal stories of those who, though eligible, have not been able to secure an appointment for vaccinations, but have witnessed those with white skin coming to community clinics in Black and brown neighborhoods being vaccinated. Next slide. In addition, we all know there is hesitancy within the Black population to participate in what they see as a government mandate concerning health. Joe Smizer of the health communications firm Public Good Project says, and I quote, "Everybody knows about Tuskegee. Everybody knows about Henrietta Lacks. What I don't often hear acknowledged is that the systemic racism that encouraged these two unethical, horrible incidents is still causing unethical, horrible incidents of racial prejudice among healthcare professionals." I am so sorry. I would put the phone on mute, but I do have a cousin who ironically is going through emergency surgery at Sloan Kettering as we speak. So I'm expecting that call too. The next slide, please. Smizer points to a 2020 study that found Black babies are 3 times more likely to survive if they're cared for by a Black physician than a white one. In 2010, he reminds us, minority women were forced to be sterilized in the US prison system. And just a few months ago, he says, Susan Moore, a Black physician, spoke about receiving racist treatment when she was hospitalized for COVID before finally succumbing to the infection. Between mistrust, misinformation, and COVID management that has not always protected the most vulnerable, think inequitable test allocations and vaccination sites, how surprising is it that Black communities have lower vaccine acceptance? And how can public health officials help change external factors and individual emotion to raise vaccine uptake? Certainly questions that must be answered by those who are much more astute than I. This problem of racism and health, as I said earlier, has been with us since 1619. It's hard to overstate just how deeply enslavement and segregation have mattered in health outcomes. From the very end of slavery onward, American healthcare has been deeply bifurcated along the lines of race, and that bifurcation has always reflected in how well people lived and how early and how often they died. Next slide. Jim Downes's book, Sick from Freedom, African-American Illness and Suffering During the Civil War and Reconstruction, explores how that bifurcation began, chronicling the role of the Reconstructive era Freedmen's Bureau in fighting severe epidemics among formerly enslaved populations. Reconstruction is primarily known for its ill-fated and ill-administered attempt to guide freedmen through emancipation, and is commonly thought of the era between 1865 to 1872 or 77. Reconstruction and the Freedmen's Bureau created what became the first public health agency for Black people, as existing municipal and charity health infrastructure built for white people in the South denied them aid. These institutions, which had historically offered universal support to the poor and depressed, began to claim they would only assist citizens of the United States, and Black people in their minds were not thought of as citizens. White supremacy brought Reconstruction to a violent and premature end. Medicine evolved along those same dividing lines of white citizens and Black outcasts. America's developing peculiar, private, decentralized, job pension-based healthcare infrastructure was only fit for a modernizing society that could not abide Black citizens sharing in societal benefits, and one where Black workers had often been carved out of the giant gains of labor entirely. Such racist attitudes about Blacks existed in the North as well as in the South. So Reconstruction by many is thought to be a total failure, and according to famed historian Leon Litvak, quote, "It failed because radical Reconstruction tested the limits of what was possible, the limits for egalitarian reform in the United States. The challenge of social equality overwhelmed the American imagination." End of quote. Viewing freed slaves as partners in democracy was a stretch for Southern and Northern whites. The notion of governance in the hands of anyone but white men was, and actually still is, hard for many to accept. The 1987 Smithsonian exhibit, Field to Factory, African American Migration, 1915 to 1940, and on display from February of 1987 to March of 2006, curated by Spencer Crew, documented, after the end of Reconstruction in 1876, the nation's lawmakers and the Supreme Court turned their backs on Southern-born African Americans and left their rights as citizens in the hands of Southern authorities. This abdication of national authority resulted in the creation of a low-tiered system of citizenship in the South, one set of rules for whites and separate, more restrictive system for Blacks. Next slide, please. Here in the North, in New Jersey, in 1895, right in Newark, Frederick Hoffman, a statistician for the Prudential Insurance Company, reviewed and analyzed the past 30 years of mortality trends of African Americans. He drew the following conclusions that illustrate the thinking of many in the state. The Southern Black man at the time of emancipation, no, I'm sorry, I'm not paraphrasing, I'm quoting directly here. The Southern Black man at the time of emancipation was healthy in body and cheerful in mind. He neither suffered inordinately from disease nor from impaired bodily vigor. His industrial capacity as a laborer were not of a low order, nor was the condition of servitude, such as to produce in him morbid conditions favorable to mental disease, suicide, or intemperance. What are the conditions these 30 years after the war, after their freedom? The pages of this work, again written for Prudential, give but one answer, an answer which is a most severe condemnation of modern attempts of superior races to lift inferior races to their own elevated position. An answer so full of meaning that it would seem criminal indifference in the part of civilized people to ignore it. In the plain language of facts brought together, the colored race is shown to be on the downward grade, tending toward a condition in which matters will be worse than they are now, when diseases will be more destructive, vital resistance still lower, when the number of births will fall below the deaths and the gradual extinction of the race will take place. So in other words, all that is saying is that our health was much better when we were enslaved. Next slide, please. Many in the medical profession have dedicated themselves to giving best treatment possible to all of their patients, those with great health insurance and those without. For many of them, it is an uphill battle, but they have dedicated themselves to treating all their patients with equal respect. We have such physicians with us and healthcare workers and social scientists with us today who will address you during the 3 virtual sessions. A survey conducted by RWJ, the survey is titled Surveys, Attitudes, Views, and Values Around Health, Equity, and Race Among COVID-19, explores deep-rooted views of those with low and middle incomes with a focus on people of color, on health, equity, and race. And the survey reports that many lower middle income were the participants in the survey and report that they see COVID-19 as a moment for change, with improving access to healthcare as they shift they most want to see. The next slide. Respondents who see an opportunity for positive change believe society should prioritize expanding access to healthcare and reducing income equality. Nearly 2/3 of respondents believe the government should ensure healthcare as a fundamental right. White respondents are less likely to endorse this statement. Black respondents report lower trust in government than white and Hispanic respondents. And as I mentioned before, the Tuskegee experiment and the case of Henrietta Lacks immediately come to mind as reasons for this distrust. The next slide. I did something wrong, so the next slide. And the next slide. And what happened to it? The next one. That's not here, so go back, I'm sorry. I must have missed it somewhere. Go back, Sam. One more, just in case it's there, and no, I missed it. Well, I had an image of Dr. Werner, who some of you might know, who practiced for over 50 years in Newark. His children often talk about spending their Sunday afternoons traveling with their dad when he made house calls in the heart of the Central Ward in Newark. The photo that I have, which I'm going to try and see if I can find during our question answering period, shows Dr. Werner when he was well into his 80s. He would set up a makeshift clinic in the intersection of Broad and Market in Newark. It was the busiest intersection perhaps in the state. And he would be down there during the day as well as in the evenings. He would have an assistant, he would take blood pressures, test for diabetes, dispense cold and flu medications, and screen for diseases that affect the poor. He could often be found, as I said, after dark, serving those who worked night shifts and took public transportation. And much to the worry of his family, provide health care for those undesirable homeless, drug addicts, and working women he knew were not getting health screenings elsewhere. So next slide. King spoke words that have since become a maxim. Of all the inequalities that exist, the injustice in healthcare is the most shocking and inhumane, as I mentioned. As we dwell in this area of Black and Brown lives matter, let us be mindful of a saying my mother said often, and I did not understand in my youth until adulthood. And she said, when you have your health, you have everything. Next slide. I have recently found a new take on that concept that says, a man who has good health has 1,000 dreams, but a man without has only one. So enough for me. And I'm now going to turn the program over to the experts who I will introduce. Kenyon Farrow is an award-winning writer, activist, and strategist. He has worked on local, national, and global campaigns on issues related to criminalization and mass imprisonment, homelessness, health justice, and LGBT rights. He is currently the co-executive director of Partners for Dignity and Rights, a national organization that partners with communities to build a broad movement for economic and social rights in the areas of health, housing, education, and work with dignity. In addition to his political work, Mr. Farrow is an essayist and author addressing difficult topics in race, inequality, healthcare, and sexuality. He is the co-editor of the book, Letters from Young Activists, Today's Rebels Speak Out. His work has appeared in many anthologies, publications, and websites. He has a bachelor's degree in theater from Ohio Wesleyan University and studied at the City University of New York School of Journalism. Dr. Robert Johnson is Dean of Rutgers University's New Jersey Medical School in Newark and interim dean of its Robert Wood Johnson Medical School in New Brunswick. According to the American Association of Medical Colleges, he's the only dean in the history of the United States to oversee 2 medical schools at once, as well as one of only a handful of African-American deans in the field of medical education. Dr. Johnson is a fellow of the American Academy of Pediatrics and serves on the advisory committee of the Division of Behavioral and Social Sciences of the National Research Council's National Academy of Sciences. He chairs the New Jersey Governor's Advisory Council on HIV, AIDS, and related blood-borne pathogens and the Newark Ryan White Planning Council. Previously, he served on many other state and national boards on medical education and certification and medical services. His BA is from Alfred University in 1968 and his MD from the College of Medicine and Dentistry of New Jersey, now the New Jersey Medical School. In 1972, with expertise in the fields of adolescent physical and mental health, adolescent HIV, adolescent violence, adolescent sexuality, and family strengthening, Dr. Johnson has become a well-recognized spokesperson for the adolescent and adolescent issues. Widely published, Dr. Johnson maintains an active schedule of teaching, conducting research, and treating pediatric adolescent patients at New Jersey Med School, and working with crazy people who call him from the Sankofa Collaborative, begging him to be on their panel. I thank you. Dr. Brittany Holom-Trundy is Senior Policy Analyst at New Jersey Policy Perspective, a nonpartisan think tank that works to make policy change, advancing social justice through independent research, analysis, and strategic communications. She researches and speaks on healthcare systems reform, the differential impact of health policies, and the role of social and cultural factors in healthcare access and health outcomes. In October 2020, NJPP issued Unprecedented and Unequal Racial Inequities in the COVID-19 Pandemic, report authored by her. Prior to joining NJPP in May of 2020, she taught at the Princeton School of Public and International Affairs at Princeton University in the Department of Social Science at the College of New Jersey. Dr. Holcomb received a PhD in politics from Princeton University in 2018. And we've already heard from our sponsors, so I think that we will go into our question and answer period. And I'm going to ask Michelle to start that, to go off with Mr. Kenyon Farrow, who is our first speaker. And I will be back, but I must call back Sloan Kettering. Michelle?
Yep, I'm here.
All right.
Dr. Holom-Trundy, are you, nope, I'm sorry. Kenyon Farrow, are you first? I was going by the
Yes.
the list. Okay, sorry about that. What have been the most pervasive effects of historical racism on the health of African Americans?
Thank you so much for the question, and thank you to Sankofa Collective for inviting me to speak today. I think the kind of persisting effects of historical racism in the healthcare system as it impacts African Americans are far-reaching. So first of all, as Dr. Epps mentioned in her opening presentation, you know, a lot of us, you know, who do this work or sometimes who talk to folks in communities, hear about, Tuskegee syphilis study or Henrietta Lacks as kind of two, historical markers for understanding, kind of persisting mistrust of health and medical systems, public health, and also of biomedical research, right? And I think that, and so one of the things I often kind of explain to people is when we think about, Tuskegee kind of happened a long time ago, right? But I often kind of remind people that the study, while it began, in the 1930s, didn't end until the early 1970s. 1972, I believe, was the year that the study was stopped. And then throughout the 1970s, there were some national kind of laws that were changed and kind of regulatory systems put in place to protect people who participate in clinical trials, among some other things. But that also, when we think about, that stretch of time, and then also some of the widows of men were given restitution in the late 1970s. And if we think about it, the next sort of, infectious disease crisis that the United States receives is the AIDS crisis, which, we recognize in June 1981. We're coming up this summer on the 40th anniversary of the first CDC report of, cases of, pneumonia and rare cancers in gay men. And so when we think about that, there was not that much time between, when Tuskegee syphilis study was still very much in the national dialogue to when HIV hits. And so it's no wonder that we also see throughout the course of the HIV epidemic to this very day, various kinds of conspiracy theories about, the HIV is man-made, those sorts of things. And then those obviously then translate into COVID, right? So some of the same kinds of frameworks around, whether it be just mistrust of medical systems and what they say to full-on conspiratorial beliefs, all kind of track through, that history, right? So I think that's one way. I think another kind of way that we don't also just often talk about is that, through various points in history where the United States was about to embark upon a, single payer healthcare system in the way that we see in other, countries in the West, that those systems, which would have definitely benefited African Americans in terms of providing baseline primary health care to all folks living in America, that those systems were often fought, and sometimes, were fought against, and were fought against also by actual physicians and doctors. So the changes to the Social Security Act, which adopted Medicaid and Medicare, or created those two federal programs in 1965, while Black, civil rights and Black power organizations like SNCC, the NAACP, the National Medical Association, which is the Black Medical Association, actually organized for the passage of those bills, the American Medical Association was actually advocating against Medicaid and Medicare, right? And we saw even the same sort of tensions in the Affordable Care Act expansion. The AMA at first was not engaged and didn't, challenge some of the proposals around a public option, et cetera, et cetera. So there are ways in which we have to also understand that just because people work in healthcare, right, even as providers, that they also aren't either watching out for their own, what they see as their financial interests, or to patients that they don't want to take care of, frankly, right? So we see a lot of, every city I've lived in the United States, or that I visited through doing my work, and then I'll stop with this comment. African Americans have a very developed, in every place, analysis of the healthcare system. People will tell you, if you get sick, don't go to this hospital. If you get sick and they take you, to this hospital and you're uninsured, that's the rich white folks hospital, and they're going to turn you around and send you to the public hospital, right? In every single city, there's a very sophisticated understanding of how people are going to get care. And so all of those things really really impact how Black people's, engagement in care, whether people have access or not, right? Just by basically having basic, health insurance or health care. And then the ways in which those systems are structured, often through kind of finances that, impact whether or not people will actually get access to care, even if they have insurance or whatever to get, to medical facilities. And so when I think about the impact of racism on the healthcare system, I think about like Black people's experiences, both historically and currently, right, that inform their mistrust and to go the extent to even believing sometimes in more conspiratorial beliefs, to just the fact that folks can't, access care in the ways that they need.
Let's think a bit about this in a little bit of a different direction then. What do you see as the connections between health in the African American community with police violence and mass incarceration?
I thank you for that question. I think it's actually an often unexplored territory. So I think that there are two pieces. One of which, if we look at the conditions of people in prison itself, right? And I would argue that prisons themselves and mass incarceration certainly creates the condition for kind of mini epidemics of various infectious disease spreads that happen in prisons on a regular basis, right? So you regularly see outbreaks of hepatitis A, hepatitis C, of meningitis, sometimes of tuberculosis in prisons. And also we're seeing it with COVID. So as late as last September, when you looked at the kind of places in the country that had the fastest COVID rates as late as last fall, the top 10 of those were all counties that the outbreaks were actually in prisons, right? So that has been kind of an under sort of discussed dynamic in the context of prisons. So both in terms of, whether it's, kind of guards who, because they're going in and out of prisons and going into communities and then, have COVID and bring it into the facilities themselves, right? And so we saw a lot of, kind of criminal justice activists really pushing for compassionate release of prisoners who could be released safely to communities rather than serving long sentences, often for nonviolent offenses, because of what was happening in terms of COVID inside of prisons. So in one ways, prisons themselves create various kinds of infectious disease, kind of mini epidemics within those facilities. There's often lack of quality healthcare in prisons, and sometimes the physicians assigned to prisons or working in them are part-time staff. And so, and in care in prisons is often kind of treated as something that you get if you've quote unquote, been good. So if you happen to fall ill and that guard doesn't like you or thinks that you're faking, there are a number of people who die in prisons because they were not believed when they asked for medical attention, right? So we've seen that happen. The last piece I'll say on this is that when we think about the impact of mass incarceration itself, there's been some work that I often think is not kind of discussed enough in terms of, because a lot of my work over the past 20 years has been in HIV, that the kind of HIV epidemic in Black America has a lot to do with mass incarceration. So if we consider in the 1980s, when again, 1981, we begin to kind of see the emergence of HIV, in the global consciousness through, gay men in the United States. But that's happening alongside the kind of beginning of the war on drugs and the beginning of the big prison boom that led us to 2 million people in prison by the year 1997. And so when you think about it, and if you know scholars like, Bob Fuller-Love and Mindy Thompson Fuller-Love, both who are in New York City, who've done a lot of work on these issues over the last 40 years, if you think about, let's take New York State, for example. At one point in New York State, 70% of prisoners in New York State came from 7 neighborhoods in New York City, right? And if you overlaid the map of HIV onto the neighborhoods in New York City that had the highest rates of HIV, it was almost a direct match. The only outlier was the neighborhood Chelsea, which was a lot of white gay men who were living with HIV, but who were not being criminalized and sent to prison in the same way that folks in Jamaica, Queens, Brownsville, East New York, Crown Heights, Bed-Stuy, East Harlem, Central Harlem, et cetera, right? South Bronx, which is where the concentration of HIV was or is in New York City. And so when you look at it that way, epidemiologists will often talk about the impact of vast migrations as a way through which infectious disease spread. So if you look at those communities and you see the kind of constant turning over of people in and out of Rikers, in and out of prison systems, et cetera, and you think about the disruption of people's social and sexual networks in those conditions, that actually had a lot to do with the kind of explosion of HIV that we saw in the Black communities in the 80s and 1990s, and less about, the DL or any sort of individual behavior. And so I think when we think about, HIV, when we think about kind of infectious diseases and we think about both the conditions inside prisons themselves that lead to these many epidemics happening, but then we also have to really look at mass incarceration as a system and what it does in terms of communities that creates the conditions through which people are constantly moving in and out, and those kinds of, in global health, we talk about mass migration and infectious disease all the time, right? But we don't talk about the ways in which prisons create the same sort of systems where people are constantly churning in and out of communities that mean their social networks, sexual networks, they come out of prison, don't have access to healthcare or whatever, and those sort of things, are unstably housed, because of the felony conviction, et cetera, create the conditions through which people are also more likely to be in ill health and contract various kinds of diseases and conditions.
Thank you so much. And I'm sure that there are some comments and questions, but I'm going to move on to Dr. Johnson, who can talk about a different population, since a lot of his experience has been in Black adolescent health. And I'm wondering if you could talk a little bit about the impact of racism on adolescent health.
Well, thank you very much for inviting me. And I think before I talk specifically about adolescence, I really have to set up a frame for my comments, because, the way you feel about something really depends upon what your life experiences have been. And so I've had a privilege of being in medical practice for over 50 years. I actually knew Dr. Werner very well, and was on medical staff with him at the old Children's Hospital and Presbyterian Hospital. And my work with adolescents has usually been around major issues that kids have. Hepatitis A in the old days, teenage pregnancy, the crack epidemic, and HIV, gun violence and incarceration. All of those things were activities I worked on. And over that period of time, my career went from directly treating young people with these problems, developing programs at a community level to address them, developing programs at a national level to address them, and then my involvement in medical education to where it is now. When it comes to COVID, it is exceedingly different. One of the issues we have right now is we're still in the middle of it, and we really will not be able to tell the story for a number of years. We have never had an experience like this. Now, the overlay of the white supremacist society in this country has been with us for years, and all those other things I mentioned were directly related to the white supremacist society in their development and the difficulty we have in addressing it. COVID-19, big time, was related to that. And the reason why more Black people and brown people were infected by it, have worse outcomes, and were more reluctant to take treatments or get vaccinations, directly related to it. But this time, unlike even HIV, which was a big conflagration for many of us, and I remember seeing my first patients and not knowing what was going on. The difference with COVID is it was fast. All of a sudden, I know it's actually just about a year. The first case in New York City was a year ago yesterday. And within weeks, hospitals were being overrun. Emergency rooms were being overrun. the supply of protective equipment we had, we didn't know what to do. We didn't have enough of it. People were getting sick. And at University Hospital, we had so many people dying, we had to bring in freezer trucks to store the bodies. We had to close down both the hospitals that I'm involved in, both in Newark and New Brunswick, to other medical care because we had so many people on respirators. And we had no answers. Initially, we didn't have any way of diagnosing it. We actually developed some of those means in Newark at the New Jersey Medical School, and we had no response to it. And it was, I've never in my half-century career in medicine seen anything like this. And as a healthcare provider, I was afraid because I didn't know, how I could or might not get infected. Fortunately, I was the second person in the state to get vaccinated, and now I'm 94% protected. But it was really different, and it changed society. And we'll eventually be able to tell the story. Now, to get to your question, among youth, the young people I see, they were frequently infected. I have over 100 teenagers and young adults that I personally take care of who have COVID. Most of them, however, were not sick at all. However, they were able to pass this disease on to their parents and other members of their society. The big problem for youth is that their society was disrupted, and that will be the continuing effect. School was gone. Even in our communities, young people, although they were highly computer literate, we did not have good networks that they could use. And the need to the one-on-one education was so different than computer-based education that they began to get behind. In addition to that, the socialization systems were destroyed because they weren't seeing other people. And so one of the things we saw in our programs was that the mental health issues began to skyrocket, and they caused a lot of other disruption. So I don't know how this is all going to work out. I think that the loss in educational attainment for all of our children has been enormous. And we know that the loss of educational attainment for children in Newark is different than it is in the white communities in our state, because the parents have other things other resources that they have. The other problem is that the Black family has been disrupted because many of the very important senior citizens in the families were lost. And that disruption, I think, is also going to have a long-term effect. So we are just beginning to learn I think we're going to learn many more problems. The other thing, and I should mention this, we don't actually know also the long-term effects of COVID infection. I said that many of the young people who were infected had very little illness. I'm not so sure they're not going to have more severe illness later on. And right now, we just don't know. We have to continue to be vigilant. We have to get to a point where teenagers and children can be vaccinated. We're not there yet. We probably won't be there until sometime in the summer. But this has been a devastating thing that we are just beginning to understand.
I thank you. And that was actually going to be one of my questions. I worried about the mental health of children and this desocialization that has just been thrust upon them through no fault of their own. I have more questions. I'm going to move to Dr. Holom-Trundy. And because you study the social detriments of healthcare, and I wonder if you could talk about some of those pre and during COVID and how it's affecting us.
Sure. I have some slides with some graphs, so I'm gonna share that really quick if I can find it.
I don't know why you don't have a crystal ball you can look into, Dr. Jones.
I know, right? Okay, let me see. Can everybody see that? See this?
Yes.
Can you still see it?
Yes.
Okay, great. I'm never really sure when I'm doing these things. Okay. Oops. No, I don't want it to play. All right. So I just want to kind of, first of all, go back and highlight just kind of the numbers we're seeing. We hear a lot about them, but I just want to remind everyone of them, even though, numbers can't, they don't tell the story, but they at least tell the magnitude of what's going on. And this is just, I went on last night and found the most recent numbers. And I first of all want to say that the reason that age adjusted is often used is, and why we want to consider age adjusted rates, is because of those exact social determinants of health, that history that has already been mentioned. Because we hear about nursing homes and the elderly being especially vulnerable, and that's very, very true in many ways. But we also have to consider, when we're looking at death rates, Black folks are not living as long in the first place. We don't have as many elderly Black folks in New Jersey as we do white elderly people. So I think it gets downplayed unless you do age adjusted rates, which kind of standardize the population and show account for the fact of how many fewer people there are by age and such in different populations. That otherwise, if you're just looking at pure death rates, sometimes people can try to downplay it and try to say, well, no, our nursing homes, that's where people are suffering. And in New Jersey, because of our history, the nursing homes are largely white, the populations there. So that's just something to remember. So when we do age adjusted rates, we're kind of seeing the real picture there. That accounts for those differences in who is even around. And so I think you've all probably seen these 10 million times in the state. They talk about them a lot, of how our Black and Hispanic populations in particular have been more exposed, have been hospitalized more often, have been dying more often, just by a huge number. And as you already mentioned earlier, vaccination rates, even though our population is kind of breaks down about this way in New Jersey. So our Black population is about 12.7% of our total population. Only about 4% of our vaccines so far, as of yesterday, have gone to Black folks. So I just want to, remind us all of where we're at in New Jersey in as far as dealing with this. But this is not just true of COVID, and I'll talk about it in a second, going back to those social determinants, but I just want to also remind everybody, as was already maybe mentioned, or was mentioned, not maybe, that this is not just COVID. This is longstanding health disparities and inequities. And so I wanted to include this graph because, I think a lot of the country this year, this past year, when they heard about the death of Chadwick Boseman, the actor who played Black Panther, of colorectal cancer, everyone was kind of shocked. And I think it was the first time people learned that Black men in particular are more susceptible to death, to colorectal cancer, and particularly death from colorectal cancer, just because it is identified so much later in Black men in particular, so much later stage wise. And there's a variety of reasons that might be, but a lot of it has to do with the way our medical system training has happened over the years, and how it's the same with our pregnancy related deaths in New Jersey for Black women. I think last month they announced that at this point they're 7 times greater for Black women than white women. These differences have a lot to do with medical care, with the fact that we don't have a medical system historically that has done well, or has even purposefully not trained doctors to recognize symptoms and diseases and listen to Black folks and when they are ill. And that's part of that dehumanization that you've already talked about in medical care. And it's in the US, it's globally too. When you talk about global human rights and health, dehumanization is a big part of medical research, of medical care, historically, when there's been segregation and such across the world. And that's, like you said, that's part of the long history. When we still have doctors, we're trying to get more doctors in who understand these issues and come from these communities themselves and are working on this. But there's when you have an institutional history like that, it can take a long time for it to actually improve. And I think that's something that people need to recognize. It's not something overnight. When we suddenly realize this is a problem, you can't, we want to just fix it overnight, and we hope that we can, but unfortunately we still have a lot of that leftover institutional, what we call it, stickiness, for medical care. And this is just some more, I just wanted to show several different graphs of just how New Jersey, even though we are ahead in so many ways, we, have the #1 education and all of these things in the country. And we are very diverse as a state. We are very comparable to the US population as a whole in many ways. But our infant mortality rates, I already mentioned maternal mortality, but infant mortality rates for Black babies are so much higher still. Just who is insured before giving birth and after giving birth, white folks are just more likely to have that private insurance and have jobs where they're getting that private insurance. So there are just so many factors that are even as we're recognizing these issues, that are still lingering effects of our long history of racism in the country. And child poverty, I think we can talk about this more in a second, but we already started to talk about this of adolescence and the challenges being faced by children. And children, health effects of children, of childhood health are very long-term as well. So the impact that an experience of incarceration or child poverty has on a person, doesn't disappear by someone just recognizing, oh, we have racism in our healthcare system. We need to find ways to actually actively address that. And this is just another example of the way that New Jersey has developed. This is the elevated blood lead levels in children, and Essex and Cumberland in particular have very high percentage of children who have elevated blood lead levels. And this is generally true. We're going to see in many maps and such of New Jersey, we see that, our counties up by New York City's, our Mercer, our counties right by Philadelphia, like Camden, and then Cumberland as well, all consistently have poor health outcomes for children and such. And this is a result of our long history of the way that New Jersey developed economically, and then historically, socially, how segregation divided communities in these areas as the cities developed. And so this in particular had a lot of effects during the COVID pandemic because of what Dr. Johnson was talking about with the speed of a pandemic like this. So the fact that every person's health is not just affected solely by their medical care, even though that is a big part, the quality of medical care and what access you have to it, but also by all of these social factors, what we call the social determinants of health, which are social and environmental factors. So these can include, as was already mentioned, housing, lower income populations are going to be more likely to have more members living in their households, live in multi-generational households where, grandparents live, and sometimes that's also a cultural factor. There's housing instability generally that can cause both stress and homelessness is a huge risk factor. Food security, access to nutritional foods, and just regular food access, having a meal on the table. Environmental, as I said, around our two major cities that kind of border New Jersey and draw this line down the corridor through the middle of New Jersey, we have higher levels of air pollution. And so lower income populations in particular, or the populations, even just how segregation kind of divided everybody, redlining and such, divided housing communities to the locations where they were. Some of these locations are more exposed to those air pollutants and these environmental variables. These older houses that have the lead pipes and have result in children having higher levels of blood lead levels. Economically, we often have, because of our history of racism, we often have people who are in higher risk occupations, who, due to the number of hours that they have to work, just as far as physical strain, but also not having access to health insurance, having to commute, all of these things with COVID really combined. And so for New Jersey, the fact that the hotspot was New York City, and it really, really spread in such a quick way before we knew really what was happening. It hit these populations, especially our Black and Hispanic populations in the state. But Essex County has had the highest death rates. It really it hit these populations in such a way that our state could have been prepared for, could have been better prepared for, I would say. And that it's still unprecedented, it's still a new disease, but emergency planning and such didn't before this take into account the fact that certain populations, certain folks are going to be more at risk because of all of these variables, not just economy wise, what might happen in a pandemic, like hospitality, the hospitality industry being generally shut down and such, but also the fact that these occupations, this housing, transportation, all of these factors really are still segregated in many ways along racial lines, and who is using them, who has certain types of jobs and such. And that's something that really we had learned about in previous outbreaks, H1N1, in previous much smaller outbreaks, we did know that there was a risk, but it just was never really incorporated. And I think that is something that with COVID, we are learning a lot more of, perhaps. I'm hoping that we're hearing these stories and taking these factors into account for the future, because it really, I think it's a big problem, but we've learned a lot, as my fellow panelists already highlighted.
So I'd like to go back to Dr. Johnson then and ask about preparing our medical professionals.
Well, I think that, yeah, the last comment were very important, and we did learn how to do this. We learned how to do this in 1910, and the United States developed a very robust public health infrastructure that involved both the CDC, public health nurses, public health activities in each state. We did also relearn the message again with H1N1 and with Ebola, and during the Obama administration, there was a panel that did advise the federal government to set up an infrastructure, because we knew that we were at terrible risk for big pandemics like this that would affect every part of our of our economy and destroy the economy of the country. Then an election occurs, and the president who came in said, we don't need any of that. And the public health infrastructure was dismantled, not only at the national level, but also at every state level. The states produce good, robust public health infrastructures because the money flows from the federal government. That was all gotten rid of. And so one of the lessons that I hope we've learned is that we need public health, even to the extent of getting vaccines out. Last year, many of us had advised the federal government that not only do we need vaccines, because we were sure we'd get a vaccine, but you need a way of distributing the vaccine. You need to rapidly produce them, then you need a supply chain. Well, the president and his administration left that all up to the states. And so it makes no sense at all that you would distribute the vaccines to the governors of the state who have no public health experience, and then depend upon some cities and some counties to do it. And in New Jersey, you have some counties where you have a good distribution plan, others where you have none at all, and people waiting on long lines. It's crazy that people who are my age, for example, have to wait on lines to get a vaccine that they really need. So all of those things are very important. And so one of the big lessons we have to learn is this issue of the public health infrastructure. Then on top of all that, there is this overriding issue of what I'm now calling the white supremacist society and all of that. And my job as a person who trains physicians and nurses is to make sure that the generation we're training is a generation that, first of all, understands what this system is and understands that in the provision of healthcare, we have to consider all the social determinants of health in order to get good outcomes. So it's not enough for someone to be able to come to see me to treat an illness, but that person, I have to understand where they live, what their jobs are, what the availability of foods are that they have, in addition to what the insurance are. I have to also understand that the structure that I'm in, the hospital, the clinics, is a structure that can be off-putting to people, and I have to overcome that. And then more importantly, I have to understand my own self and to what extent I am racist and what extent the biases that I have affect the way in which patients relate to me. Now that's what we're teaching our students. But as was said, we have 150 medical schools now. Most medical schools are teaching that. It will take generations before we develop the generation of the health workforce that can do that. The other thing is that the health workforce needs to be more diverse. We need more Black and brown physicians. And so every medical school in the country is trying to do that. The issue is we can't just produce the people who come into our schools. They have to go to college. And so we need to have more Black and brown students going to college. That means more of them have to graduate from high school and more of them have to graduate from middle school. And so the long-term thing is we need to improve the education system so that we can have better educational outcomes for young people that then give them those greater opportunities. So at least we have a better understanding of this now. We are approaching everything, but the solutions are some short-term, but many of them are long-term. And I'm really afraid that we society will get exhausted. We like short-term solutions. Every time I got interviewed by a reporter who found out that Black people are dying at a faster rate than everybody else. And she wanted to know what's the solution? What can we do next week? Or what laws can we pass to change this? And then when I go back to my old song and dance about the education system and change the society, people just glaze over. And so we want to solve the problem quickly. That's great, but we have to have the patience to understand the depth of the problems and begin to work to change them over the long run.
And then with your previous comment about not being sure of the impact that this isolation has had on our children, I would imagine complicates the problem even more.
Absolutely, absolutely.
Even more. I'm going to go back to Mr. Farrow, and because I know you're in the area of public health a lot, and I'd like to know, and you're in New York, I believe, right? And I'm going back to the comment about those areas and rates of infection, and to see, or to ask you, actually, this is for all three of you, what can we as the public or individuals do? What kind of impact do the Black Lives Matter movements or other movements have on the work that you do? How can we be helpful?
Thanks. Yeah, I think, and I'm actually no longer in New York. This past summer moved back to my hometown, Cleveland, Ohio. So I'm
Oh, fun.
yeah. So but once things open back up, I'll be in New York a lot again for work.
Okay.
But anyway, so I mean, I think that there are a few things there that we can do. I think one is we actually it's really critical that Black-led social justice organizations consider health and public health at the same level of importance and critical need for organizing, agitation, and activism as we do when someone dies at the hand of a police revolver, right? And I think that often, we understand the kind of racism in institutional, healthcare and in medicine, public health, biomedical research, et cetera. But when you look at the sort of premature death rates of Black people from health-related issues compared to, say, police violence, I mean, I don't even know what the rate is, but it is probably exponentially higher in the first category around things that are caused by various kind of health disparities. And but when you compare that to the number of organizations in our communities that are focused on sort of issues pertaining to the community, they're fewer and far between. And some of that is also about funding. I can tell you, I was almost recruited a year ago by a search firm looking for somebody to join a foundation, right, in philanthropy to fund racial justice projects. And I ultimately didn't take the interview because I was told, when I talked about my interest and one of the things that I would be looking to fund in terms of racial justice are, kind of community-based, organizing and activist projects that are focused on health-related issues. I was literally told that really their portfolio is focused on, kind of school to prison pipeline and education, and also kind of policing and prison apparatus. So I think one, and this is a call out for any folks who work for foundations that actually need to consider that health-related disparities are actually a part of what it means when we say Black Lives Matter, and that those organizations that are doing that work need to be funded to do so. And right now, really what we have in that space is, some grassroots like HIV organizations that do that level of activism, and then some kind of folks who do reproductive justice work or whatever in the community. But to think about the healthcare system writ large, we have less support for that kind of work. And so to me, it also reflects in when, communities, so now we're here in the middle of a pandemic, and I'm getting calls off the ringer to do events like these, which I love doing and I'm so glad to do. But in some cases from organizations that I have relationships with that were really not doing anything around health-related issues concerning African Americans, although they're, Black sort of like social justice organizations. And so now trying to back into explaining to people how vaccines work, what they do, what they don't do, how these vaccines were developed so quickly, at least to the public, although the mRNA technology was really being developed for 12 years before COVID, but like having to explain these systems and for social justice activists who really have the ground level ear of the community and can translate that stuff to communities, we're now trying to back into some infrastructure to do that work that we have ignored, as was said earlier, for so long. And to me, those are some things that I think that we really need to be doing more as a community.
Okay, thank you. We're down to our last 15 minutes here, and I don't know if there are any questions in the chat because I haven't been looking, and I don't want to I want to allow our audience to have their questions be heard if there are any. So Michelle?
It's a quiet group today. So if anyone has a question, now would be the time to share it.
Can I make a, I'll just comment while we
Go
wait
for
for
it.
maybe a question. I just want to say that I think my fellow panelists' comments just before now it's really important, because I think there's a tendency right now amongst policymakers and such to approach this, like with 2020 and with the Black Lives Matter movement and such, there was a recognition of, oh, okay, we have a problem. We've seen this problem before. We really recognize this problem now. And this idea of, oh, we can just impose some solution and everything's fine is just false. And so I think the idea of agency and like getting voices, like actually listening to what's needed and adjusting to that, not just going and saying like, oh, I think this is what we need, like this, you know, this is the one solution and we can just address this one thing and everything will be fine. And recognizing, as was just mentioned, about like what foundations are funding is going to produce a certain type of research or a certain type of activism, you know, recognizing patterns in all these different pillars that are happening, and trying to actively address that is really, really important. And so I just want to highlight how important those comments were.
Actually, Brittany, I've been thinking about something while all three of you were talking today, and it had to do with something I heard on the news this morning, because the last few weeks, the news has been full of stories about how parents are just demanding that kids get back into school, right? We have all heard this all over the place. Well, I heard a report this morning about a Pew Research poll that showed that, well, the loudest voices are affluent white families that want to get their kids back into school, families of color, and I don't know. I was out on my morning walk. They didn't specify a whole lot, but they were much more reluctant. So it really kind of makes me think of the things that you were talking about, the suspicion of the system, the need for education. I mean, it really hit on what all of you were saying, the need for education and the need to get into the communities and finally to really work with people to empower them to have agency in making decisions for themselves and their families. So I just wanted to throw that out there if you all had any thoughts.
So I saw the study. I don't know what it means, but it did have, I think, that only about 30% of parents and they actually used the code words, parents from urban communities want their kids to go, and suburban communities, 67% wanted their kids to go back in school. The problem with the way studies are reported in the media is you don't have enough detail to really understand what it means. It very well may mean that parents in the urban community, the Black parents, don't feel their schools are safe. Well, that's a pretty reasonable solution, and white parents that can perceive their schools as much safer. So I think that we've known their differences for a long time. I'm not sure that this issue of getting kids back into school is one that also is not coded for a racist purpose. It's not just getting kids back into school. It's doing a lot of other things for kids that need to be done. And so I'm always cautious about things like that have these dichotomies between us and them. And there's usually a lot more behind it.
I see that Janet Field has her hand raised. Do you have a question in the chat, Janet?
I couldn't find the chat to type it in, but yes, I just wanted can you guys hear me?
Yes.
My question goes to Brittany Holom-Trundy. I was just curious as to where you got your information or your statistics from when you said that seniors, as far as, Black, white, that Black ones aren't living as long, longer.
So are you talking about in New Jersey, the COVID deaths, or?
Oh, I don't know if you meant it as COVID or as a general statement.
Yeah, both are true. That generally in our population, we have our elderly population is more white. Just for a lot of different reasons, like life expectancy is lower for Black and Hispanic populations. And so, and that data comes from the New Jersey Department of Health and the CDC, you can find it as well. And the Census Bureau has this data as well. But and they also have the COVID deaths too, and you can go, the New Jersey Department of Health has a dashboard where they put a lot of the graphs I had today were from there, where they put data, and you can break it down by race and age and gender, though they don't have it really updated to the new discussions about gender, but you know, they have it all broken down on there. So yeah.
Thank you.
Yeah.
I'm going to ask you to remute yourself, Janet. We were getting a little feedback.
And I've got a question for Dr. Johnson that came up in the chat. Dr. Johnson, please address disparities in treatment of Black patients and in the delivery of care in institutions that are still overwhelmingly white and biased based upon long-held misconceptions about Black patients.
Well, the first thing you start with is that the health systems or the institutions have to accept the fact that there is bias and that bias has adverse health outcomes. That's because, you know, institutions won't do anything unless they accept it. Unfortunately, at least the health institutions I'm involved with in New Jersey are taking this on. They and have said, yes, this is true. They've been able to look at their statistics for outcomes for Black and Brown people and see that's different. They look at the experience of their employees that are Black and Brown, and they even have studies that show how those experiences are different. Then once you do that, then you can begin to develop means to address it. And so in New Brunswick and in Newark, we are engaged in training in unconscious bias among all of our faculty and staff. We have robust programs for students, and we have on our practicing providers as well as our staff, we have programs that are just students. Now, it is going to take a long time before that gets reversed, a very long time. I'm giving we have a course in medical school that I actually teach in just on all these issues. So it is happening, but I don't think it's going to get really different in my lifetime. I think it's very important that we begin to develop the health workforce where this is an important issue. It is no surprise that one of the reasons why this is really being taken on now is that the complexion of the leadership has changed, but we have to continue to press the importance of this. Now, the other side of all this is that there's an economic issue that we save money if we have a healthier population. We get better outcomes as far as work productivity if the population is healthier. And so that approach is one that is also quite helpful in making sure that we begin to do all this. The other side of all this too is that we need to have healthcare receiving public demand this, so that that if you experience an adverse experience, have an experience that's an adverse experience, you should complain right to the head of the hospital. If you have, and the electronic health records now have a way in which patients can interact with the system and actually write that into the system. And that is important because it documents the experiences, and those experiences actually will result in lower payments to the healthcare system. So there are things that can be done. More people need to know about this, and more people need to be engaged in it. The thing we don't need to do is deny it's there. And I think that is the most dangerous thing when people say, no, it's not there, or, racism ended in 1863. Well, or things like that. And that mindset is one that makes it worse.
Can I add to that really quickly? I think this is something that and maybe it will be addressed more in some of the coming panels too. But as far as money, the way money flows and everything like that, how it doesn't have to be someone calling someone a name that exhibits racism, like the way racism has manifested itself in our system. Just as I can't remember who mentioned it before, but the way that our medical system is funded, that in New Jersey, for example, more like in the graphs I showed, more like Black women who are giving birth have Medicaid as their insurance, and just like the reimbursement rates and how government reimbursement rates are often lower than private insurance, and how that's seen in the way as like insufficient, and just the types of problems it produces are really important, and that I think people need to recognize just how complex it is, like how many different aspects of this there are. As you said, it's not just, oh, well, we outlawed this, like it's fine now. That's not the case. And I'll kind of move to the question that's in the chat. I think there's a couple questions in the chat. So the one that's addressed to me,
I was just going to read that too.
I'll
Brittany,
I'll kind of connect this
so
to that. In our work at my organization, we talk a lot about government funding and like where it's going and how it shows what you're valuing. And there are some ways that they try to provide money for like graduate medical education and stuff, to try to encourage folks, Black folks to take up medical, go into the medical field. But I think it's still insufficient in New Jersey. Some other states have some more robust programs of specifically addressing this. And it's not just, oh, we'll give you some money for a few years if you go and work in a low income area. Like they have a little bit more developed programs. And so I think there will be a push for that. I think it's still developing. There's still a lot of conversation policy-wise, and again, I think this might be talked more about in the coming panels, but as far as how to better address data collection so it shows the real picture, as was already mentioned with the surveys, like research and stuff, if you hear just one stat, it doesn't always tell the whole story. So how to do that better for both policy and research generally, but also how funding can be distributed or shown to actually be helping, rather than just kind of be a name only. We're throwing some money into a fund and hope it helps. So I'll just leave it at that, and we can let my fellow panelists answer questions.
I have a question directed to Kenyon and Dr. Johnson. What are the alternative practices, supports, or systems Black folk can depend on given research and thinking about doulas, nutrition, etc.?
I'll respond quickly first. I think, well, we Black folks have a rich tradition of, doing a range of those things, right? So we have a rich tradition of Black midwives and of, and then the folks, who, are promoting, kind of nutrition, more plant-based or vegan diets, et cetera. And I actually just see a real uptake, particularly around diet issues in the Black community. My aunt, who is like 66 years old, became a vegan 2 years ago. And so I'm was beginning to see, I think, some of those kinds of changes. But I think that we actually, most of the things that I think that we need actually have to be brought to scale, which means that like we can't just rely on, kind of grassroots or, ad hoc community efforts. Those things have to be organized to actually really change real structural policies around, environmental issues, food access issues, and then around the issues that I work on in public health, which are infectious disease, which I often have to remind a lot of Black folks cannot be explained away by, or cannot be dealt with by changing your diet, or some of the, quackery on the internet that I write about and some of the things I put in the chat. Infectious diseases cannot be changed by some alkaline diet or some, whatever. Like those things involve, bacteria and viruses and things that really require, medicine and real trained medical professionals to address. So I don't want us to lose sight of like those systematic things for wanting to just do, things that are done at very small scale that are useful, but may not have ultimately the grand impact that we want.
Mhm.
Kenyon, I'm really happy you answered this question first, because I usually get into trouble when I get into this one.
I'm okay being in trouble. So it's fine.
Yeah, because, listen, I'm in organized medicine. I head the dean of 2 medical schools. I do research. I've been on all these national panels. I completely endorse what Kenyon says. The science is the science, and the science is good. The science has taken advantage of us, but the science is the science, and we have to make sure that we we use treatments that have good science associated with them. We need to be more involved in the science, and you might know that the person who was largely responsible for the development of the COVID vaccine is a Black woman. So we need to be in there. But these other things that are smaller, not to scale, not based on science, are things that we don't really, it's not an advantage to us to do those.
So I think we're now at 2:30, and I would like to very warmly thank our 3 panelists. I don't think we could have asked for a more thought-provoking and robust conversation than what you have provided for us today. So I'd like to remind everyone that this is just part 1 of our Health as a Civil Rights series. Part 2 will be next week at the same time on policy and racial health disparities. And part 3 will be on March 18th, again at the same time, 1 p.m., on community responses to racial health disparities. We have 2 of our panelists who will be back again to discuss those 2 issues, but they'll be joined by equally intelligent and probing and well-trained professionals, healthcare professionals. So we invite you back again. We thank you for supporting the Sankofa Collaborative. As usual, this program was brought to you for free, but we do accept donations. We welcome donations. I'm not going to say we beg for donations, but it's how we keep providing programs like this to you. And we do have several more lined up for 2021. Hopefully we'll get to the point in the fall where we can be in person, not counting on it, but we are planning on having our full season of programming for you this year. So once again, thanks to our panelists. Thanks to all of you for tuning in and being a very gracious audience. And hopefully I will see you again next week. Okay.